America's biopharmaceutical companies have one very important thing in common:
a common enemy.
We're making great progress because we're collaborating in ways that we've never done before.
In a matter of weeks, we've progressed from potential treatments
to antibodies and antivirals that have shown positive results.
to several promising vaccine candidates.
Because science
is how we get back to normal.
Good morning. Can you hear me?
Hear you loud.
Welcome, everyone. Let me get my screen share up. Can you see my screen?
Yep.
Great. Good morning, everyone. Thank you so much for being a part of this most unusual NMQF Summit. We wish we could be in person together on this beautiful October day here in the Washington, D.C. area, but nonetheless, we can continue our work together to promote health and equity, as the slide says, and we'll be focusing on diabetes, flu, and COVID. I am asking that you all put any questions in the Q&A box. That's where we will look to engage and respond to you. I want to thank some folks before we get into it. Naomi Oladibi is the program manager for our SHC projects. Angie Bricco has been a stalwart and creative and dedicated partner at Sanofi in terms of helping to promote health and equity. Kellyanne Collins and her team at Vault Lab have really been doing outstanding work in terms of communication support. And then you see our supporters for the various programs we'll discuss. I want to introduce the panelists to you, and they will actually be speaking in this order. The first panelist after my introductory comments is a man who needs no introduction, Dr. Puckrin, who is the founder and president of the National Minority Quality Forum. Another man who needs no introduction is Dr. Keith Ferdinand. He's from the Tulane University School of Medicine and is an amazing cardiologist who has worked diligently for so many years to promote good health outcomes for people of color and people suffering cardiometabolic disease. Rashida Ferdinand is an amazing person who founded Sankofa Community Development Corporation, which meets the needs, the social determinant needs, if you will, in New Orleans in the lower Ninth Ward. And it's been an honor to work with her. Similarly, Dr. Nuss, who is with LSU's Public Health School, has been working with us to evaluate the impact of our program, and we really appreciate his support. Last but not least is Helen Artiego Landaverde, an amazing woman who founded a federally qualified health center in Corona, New York, and a place that was one of the hardest hit early on by the coronavirus, and is so dedicated to serving her diverse community. It's an honor to be in the company of all of you, and I thank you. So thank you. So we're going to tell you a story about the need, the science, and the efforts to promote health in diverse and underserved communities, especially as it concerns diabetes, flu vaccine, and COVID-19. But most importantly, we want you to become a part of the story. I didn't really introduce myself. I'm the president of the Center for Sustainable Healthcare Quality and Equity, SHC, brought in by Gary 3 years ago to really translate the massive amounts of data he has collected over the years into something actionable so as to promote sustainable, healthy communities. That's what SHG is all about. And what we'd like you to do, or consider yourself invited to join us in creating a nationwide network of clinicians and community leaders to promote sustainable health in diverse and underserved communities. We have been putting together, in addition to programs and research, tools that can help you implement change if you're a clinician or a health leader or a community leader. Drive, demonstrating real improvement in value and equity. I'll share the link with you in a moment. What are the things we do? Research, identifying need. So we recently published an analysis of Medicare fee-for-service data showing how significant the disparities were between people of color and whites in terms of receiving a flu vaccine, especially high-dose flu vaccine that you see here on your right. This is the disparity. In a Medicare program, so this is a public program. We publish. We think it's important to communicate results. For example, we promoted in a publication the absolute unacceptable gap in influenza vaccine coverage and how we needed to use evidence-based, community-centered strategies to remedy it. We recently surveyed members of our network. At the time, this was in April, we had 40 some members. Now we're up to 70 about COVID-19 impact. And I would just highlight for you that the #1 issue that was expressed was the need for help in communicating with patients. I think that the people who are in underserved communities are so dedicated to their patients. What else do we do? Help you change your practice. Helen has been part of this program. That's a big, long slide, and I'm not going to go through the details. I just want to share with you that we've worked with a diverse group of practices of all kinds, and they were all able to increase flu vaccination rates, even if they started in January. And it was really through team-based training, really engaging the medical assistants and nurses on making a strong recommendation and looking at their data. There was some healthy competition as well. See which pod of clinicians would get the highest rate, and acknowledgement of those champions. And their work was sustained over the next year, because once you really commit and become part of Drive and a sense of applying quality improvement to health equity, you create a different culture in your practice. So in the face of COVID-19, to continue our efforts in quality improvement, it's on all hands on deck. So what can be done now? Forgive me for popping up some of these boxes here. In terms of flu vaccination, we're basically saying all healthcare providers need to be involved in either providing a flu vaccine, so very important during COVID, or recommending it. There needs to be training at the practice level. There needs to be increased attention to safe access to the flu vaccine and attention to providing high volume access, such as mobile and drive-through. And maybe most importantly, engagement of community leaders in the planning, communication, and even vaccine provision. In this era of such great distrust and strife and suffering, trust is kind of the currency that will help us help communities protect themselves from illness like flu. We think that it should be targeted as well to communities of color, which are especially susceptible to COVID and thus getting a flu shot is even more important. Communities with historic low rates of flu vaccination, and as I noted, communities hard hit by COVID. This cartoon is basically showing how in our hands, we are supporting communities and practices in promoting flu vaccination. The trust through patient and community engagement is number one. There are evidence-based approaches that can lead to the change, expansion of the pool of providers, and new workflows that make use of mobile, outdoor, and safe strategies in a COVID era. I just wanted to say again, nor has building trust between healthcare and community been more important. So what are our resources? What are we inviting you to partake in? We have guides to safe and high volume vaccination practices. We have video training on making a strong recommendation. We have educational slide sets, communication tools, and even some grants for local programming. We have a wonderful series by Shanina Knighton of infographics that are culturally sensitive and really practical in terms of how to protect yourself from flu. We have our Drive Toolkit that is supported by a monthly coaching call on the last Friday at noon of every month. But we also can provide a call of individual support as you launch your effort. And we want to spotlight your efforts and not just be the ones kind of presenting, but giving you an opportunity to share with your colleagues around the country successful efforts and provide you an opportunity for recognition as well. We have a huge community and clinical leader toolkit with all kinds of templates for letters to the editor, social media graphics and messaging. We're even having some sermons that will be available soon. And you see some pictures of those down there. I've been talking about flu vaccination a lot, and much of the program today is going to be about diabetes, but I want you to be aware that we have activities in all of these clinical spaces. So we'd really like for you to join us and become a part of the network that is going to assure a better tomorrow with sustainable health in every community. Here's my email address. Send me an email. I'm going to stop sharing. Turn it over to my boss, Dr. Puckrin.
Hey, Dr. Puckrin, you're on mute.
Thank you. So let me share my screen. So the National Minority Healthcare, we've been collecting health data now for about 20 years. We have a database of over 5 billion patient records. We collect data on about 130 million lives a year. In working through all of that data all of these years, one of the things that I've walked away with is the difference between managing financial risk and managing patient risk. A lot of our healthcare system is focused on managing financial risk. If you look at the programs that come out of Medicare, pay for performance, CMMI, value-based purchasing, they're all about managing financial risk. The presumption is that they are also having an impact on patient risk. But what I want to talk to you about and show you today is the difference between managing financial risk and managing patient risk by focusing on diabetes in the Medicare fee-for-service program. So one of the things that we did was we took all of the Medicare fee-for-service beneficiaries and we put them into 5 buckets based on how much Medicare is spent on them in 1 year, exclusive of prescription drugs. And this is actually some work that we published back in 2007. And this model has not changed. In 2007, we were looking at the data from 2000 and 2006, but 20 years later, it hasn't, the model hasn't changed. And so what we see at the top of the pyramid, we call them crisis consumers. Medicare is spending about $160 a year, $160,000 a year on their care. And then below them are heavy consumers. So between crisis and heavy consumers, they're roughly about 17% of all Medicare beneficiaries, and Medicare is spending 71% of, 71% of all of the dollars spent on diabetes care in the Medicare fee-for-service program is spent on these two clusters of patients. And what they're spending it on is hospitalizations. And I'll talk to you a little bit more about hospitalizations in a moment. Down at the bottom of the pyramid are low consumers. Medicare is spending roughly, on average, about $1,000 a year on their care. So you've got about half of that low consumer group who Medicare is spending less than $1,000 a year in their care. We did some work. We took the ADA guidelines and we lined them up with a Medicare reimbursement schedule. And what we can say is if you are following the ADA guidelines for the management of diabetes, then it's going to cost you more than $1,000 a year to provide care to patients with diabetes. So the way the system works is basically those crisis consumers, they have very high mortality rates. Their mortality rate is about 26% per year. Even these heavy consumers, they have heavy mortality rates, high mortality rates as well. So what happens is that those low and light consumers here, they migrate over time. They become the crisis and heavy consumers. And so what's happening is because Medicare fee-for-service is paying so little for the care of these patients, they're spending that money up here. And so they're not providing the preventative services and interventions that are needed to keep these populations from migrating up. And basically, when you look at the data, these crisis and heavy consumers, they're suffering from organ damage. They have heart disease, they have kidney disease, they have COPD, so they're getting major organ damage. And once they have that, they don't come back really. Their costs stay high, and they have a high mortality rate. And so just to give you a sense of what the mortality rate is, and so looking, this is 2017 data. Now remember, I showed you 2006 data. 2017 data isn't very much different from the year 2000. So that crisis consumer group has a 26% mortality rate. Over 3 years, 78% of them will die. Those heavy consumers, about 52% of them will die over that 3-year period. And it's this group down here of these light and low consumers that migrate up and cost the system. So much of our national dialogue about care is dialogue about managing financial risk. But what's really important is managing patient risk. Because the point is, we cannot eliminate health disparities if we don't intervene early with patients. We can't help the underserved if we're going to just focus on managing financial risk. And so if we want to reduce acute events for those low and light consumers, that is, reduce their hospitalizations, ER visits, disability, and mortality while improving their quality of life, we have to learn how to manage patient risk as the driver. At the National Minority Quality Forum, we would argue that the prime directive of our healthcare system has to be about managing patient risk. No patient goes into the healthcare system believing that the system is going to elevate their risk. And I'm telling you that the system is elevating patient risk by its attention to financial risk over patient risk. Just to give you just a final feel of what I'm talking about, just in sheer numbers here, 57% of the spend in diabetes, for diabetes care in the Medicare fee-for-service program is spent on hospitalizations. And we think a lot of those hospitalizations can be avoided. These are hospitalizations and emergency room visits, sorry. We think that those hospitalizations and emergency room visits can be avoided if we applied appropriate care. So one of the things that we'd love for you to focus on, we'd love to collaborate with you on, is this whole idea of managing patient risk, because we believe that it's highly predictive, that we can create models and predict patient risk and then try to intervene before they become those crisis and heavy consumers who have organ damage with high mortality rates. Thank you.
Thank you, Gary. It's really my pleasure to participate in the programs that have been done by the National Minority Quality Forum and SSR in terms of decreasing cardiovascular morbidity and mortality in persons with diabetes. And I'm going to specifically address what we call the triple pandemic: diabetes, influenza, and COVID-19. I am one of the members of the Healthy Heart Community Prevention Project. We've been working in New Orleans, Louisiana for 3 decades. We pioneered along with the late great Elijah Saunders in Baltimore and B. Wayne Kong, doing blood pressure interventions in barbershops and beauty shops and at sporting events. But our most recent endeavor has been with Sustainable Healthy Communities in the New Orleans Diabetes Collaborative. And what we have been trying to do is, and I'll show you some of our outcomes, is to prevent and treat diabetes and decrease the worsening complications by patient education. I'm a cardiologist, but I always have suggested early on in the process that if we want to keep persons with diabetes out of the hospital, make sure that they get vaccinations. And I'll summarize our Healthy Heart efforts over the last 18 months. Because of the pandemic, we have not been able to do the type of in-person direct communication with our community, but we expect that we're soon going to be able to do that, and we're going to build into our platform education about COVID-19 and its disparate impact in the minority communities. As I mentioned to you, as a cardiologist, I've always been aware, panel D of non-Hispanic whites, panel E of non-Hispanic blacks. The top dotted line are all forms of cardiovascular disease, and this is the #1 cause of death, including persons with diabetes. But if you look at the height of those curves, it's markedly higher when you compare whites to blacks for cardiovascular disease. And we can't really just talk about mortality or death. It has a great impact on the psychological status of the Black community with early premature death, the loss of mothers and fathers, and an economic impact with those persons who would be working for decades who die prematurely. Diabetes, as most of you know, is disparate in the non-Hispanic Black community here in the red, and also in Hispanics here in the green. And specifically, when we do geomapping, if you look at some of the hotspots, one of the greatest hotspots is in the Mississippi Delta at the bottom of the Mississippi River, where New Orleans lies, where you have one of the most potent risk factors, very high, that is comorbid for diabetes, hypertension, and diabetes itself. This is one of the slides that we use in our education, that we try to get patients with diabetes and hypertension to understand the negative impact of refined carbohydrates, fat, sodium, and excess calories. And we use evidence-based information such as this from the Association of Black Cardiologists that talks about the plant-based approach. You don't necessarily want your clients all to turn to vegans, but you want them to understand that high potassium, low potassium foods, low saturated fat, avoidance of refined carbohydrates is beneficial in persons with diabetes and cardiovascular disease. Gary had a very nice slide. He didn't have much time to go into detail, and I won't either. But we now know as cardiologists that at least two of the newer classes of medications, the GLP-1 receptor agonists, which are injectables, and the SGLT2 inhibitors, which are oral agents, now appear to be cardiovascular protective methods of decreasing disease. The GLP-1 agonists decrease atherosclerosis and have some renal effects. The SGLT2 inhibitors decrease hospitalization and cardiovascular death with heart failure, even without diabetes. Two major trials, the DAPA-HF trial using dapagliflozin and Emperor reduced using empagliflozin, have shown that benefit. Also early in the process, I said if we want to keep persons with diabetes from having early death and keep them out of the hospital, we need to make sure they get flu shots. And I think it was a little bit off the talking points when I first was pushing this, but I thought it was important for us to recognize the impact of flu and its complications in persons who are 65 years and older, and persons who have certain conditions, including diabetes, heart disease, asthma, clotting disorders such as sickle cell, chronic kidney disease, autoimmune disease, extreme obesity. All of these are disparate in the Black community, and all of these would lead us, if we want to help people live longer and better lives, to look at influenza vaccination as a pathway to better health. This is one of the slides that we use when we teach our patients. We let them know that if you have diabetes, you have a 3 times increased risk of being hospitalized. And if you get vaccinated, you decrease the risk of getting sick with the flu, you reduce hospitalization, and we actually teach them how much reduction can be done. This is directly from CDC. You can reduce hospitalization by 79% in persons with diabetes by using vaccination. Remember that number, 79%. The New Orleans Healthy Heart Community Prevention Project then initiated its methods of going by geomapping, looking at the zip codes, which were predominantly African Americans. We wanted to increase vaccination use, teach patients and improve self-efficacy in community centers and faith centers. And we wanted to focus on diabetes, heart health, and influenza vaccination using evidence-based, non-commercial, culturally appropriate materials. We use physicians to do the training, but I will tell you that much of the organization and the actual impetus of Healthy Heart has been done by a PhD in nursing, Daphne Ferdinand. We had pre and post surveys for education to show retention of information, and these interventions would happen 1.5 to 2 hours. One fine point is that we didn't set the time. We would do it on weekdays, during the day, late in the evening, weekends, whenever our community centers and our faith centers wanted us to be available to have these sessions. Here are some of the data. You'll note that when you look at the collection of the 2018-2019 data, almost 40% of the persons were positive for having diabetes, a very high rate in the New Orleans community. These are some other data, 2019-2020. You note the sample sizes are somewhat smaller because the pandemic hit New Orleans in March of 2020. February 25th, 2020 was Mardi Gras. I was out there in the street with others, and we had our first case of COVID-19 in March, and we were a hotspot thereafter. But you again see high rates, disproportionate rates of diabetes in the New Orleans community. Here are some of the questions. We actually teach our patients to break through this idea that there's this group of numbers and Latin sounding words that you can't understand because it's the province of the doctor. We want our patients to understand. For instance, understand that if your glucose is 126 or above on 2 occasions, that's diabetes. We want them to understand that foods that are high in potassium are good for blood pressure and hypertension, and the other things are adverse. And we actually embrace the more ambitious goals of less than 130/80 for blood pressure control in persons with diabetes who are at high risk. And remember that number, 79% from the CDC data, we actually tell our patients that if you get vaccinated and you have diabetes, you can markedly reduce your risk of being hospitalized, and actually want them to know that number. And then finally, remember I discussed those patients who are higher risk. Most of the patients that we were speaking to were higher risk, the volunteers, the community members, and we wanted them to recognize you are high risk from getting complications of the flu. So the answer was all of the above. This is the type of learning in the post-test that took place, knowing the numbers for diabetes, that you need more potassium, that more ambitious blood pressure reduction may be beneficial, and knowing that most of you are going to be high risk. Here are some pictures of the type of things. This is a community center in the lower 9th Ward where Rashida is going to follow and talk about Sankofa. I'm a child of this neighborhood, and we directly go to the seniors and talk to them about these, what we consider somewhat advanced concepts, but I think are life-saving concepts. This is Franklin Avenue Baptist Church, a large church. This is one of their community center rooms in which we directly talk to our community about risk. And we pioneer the concept of doing flu vaccines on site while we're doing the education. And this is going to be done with commercial pharmacies from the area. All right, let me transmit my conversation now to COVID-19. Again, we have not been able to directly talk to our community as we would like about COVID-19, but we expect that we're going to do that very shortly. As you know, it's mainly a respiratory virus, but it does have effects on the heart and the vasculature. In fact, we're now getting more data that patients have heart failure, myocarditis, inflammatory vasculitis, and even strokes. And we've seen this in younger persons with COVID-19. One of the things that we also recognize that when you look at Black or African Americans, this is directly from the CDC, in terms of cases, 2.6 times higher, hospitalization, 4.7 times higher, and death, 2.1% higher. And similar, we see these type of findings in the Hispanic Latinx community. One of the things that is often said, well, why do you see in this minority community more hospitalization, more death from COVID-19? Perhaps it's something genetic. No, it's not. The underlying conditions that cause cardiovascular disease are the same underlying conditions that makes the person more likely to be hospitalized and die from COVID-19: hypertension, obesity, chronic lung disease, diabetes. And if you look at the age range, whereas hypertension is very common in the older population, you see in the younger population, in the gold and in the blue, diabetes and obesity. So in New Orleans, for instance, we see patients who are hospitalized who are in their 30s and 40s who have diabetes and obesity, who have COVID-19 with an increase in mortality. This is a quote that I offered to the National Geographic. They called and they said, you know, what's going on down there? Why do you see this high risk in African Americans for hospitalization and death from COVID-19? And the quote that I gave was that it was a mixture of difficulties faced by African Americans that compound or extend the burden of the coronavirus risk. The pandemic didn't just cause these disparities, it unmasked them. It showed to the country that these disparities in cardiovascular risk, diabetes, obesity, hypertension that have been going on for decades now compound COVID-19 hospitalization and mortality. And that's the message we're going to take to our community when we're able to do some more in-person community education. And working in what are called essential jobs, where you can't work from home, increases your risk for COVID-19. Construction work, transit work. Similar to what's seen in New York City, we saw that in New Orleans. Those persons are more likely to get infected, more likely to be hospitalized, and more likely to have an increased death, and they're disproportionate minorities who work in those sectors. This is directly from the CDC website, and I agree with it, that some of the findings in COVID-19 are also a reflection of discrimination, health access and utilization. I mentioned occupation, education incomes, wealth gaps, multi-generational housing where you can't space out, you can't get social distancing, even if you've been infected within the home. And even the mitigation methods themselves, where we try to bury some of the risk of COVID-19, has an unintentional harm with lost wages, reduced access to services, increased stress, And this is going to be hiring persons who don't have disposable income. This is an editorial that I wrote with one of my colleagues in the Journal of American College of Cardiology, and I stood up at night trying to figure out what I'm going to call this COVID-19 mortality. And what came to me was that it's a sentinel event. In hospitals, the Joint National Committee, when they see in your hospital that you have people who have retained objects after surgery, retained sponges, you have patients who've fallen out of the bed and broken their hips, they call those sentinel events. And they want to look at that hospital very closely because of these serious physical and psychological injuries. Well, similarly, I think the disparate African-American COVID-19 mortality reflects longstanding, unacceptable US racial, ethnic, and socioeconomic cardiovascular inequities. And COVID-19 then unmasks the system's failures, which have been longstanding, that need to be caught and mitigated. Here's some of the steps that I have suggested. These are my own personal recommendations. That one of the boxes at the top, test beyond symptomatic persons. To wait until people are symptomatic is too late because they've already become vectors. They've already started to spread. Our early testing was done in shopping malls. People were driving with their cars, but a lot of disadvantaged persons don't have cars. We need walk-in facilities. For instance, with Hurricane Katrina, 40% of people in New Orleans who cook the meals and clean the hotels downtown and work in the convention center catch the bus. Well, they can't drive to the suburban mall in order to be tested for COVID-19. We also to encourage telemedicine, blood pressure monitoring, home scales, heart healthy eating tips through education at home, and tell our patients that if you have symptoms of heart disease, shortness of breath, chest pain, weakness, that you should seek emergency care. Many patients were staying at home, having heart attacks, heart failure, strokes, afraid to go to the hospital because of COVID-19. So Healthy Heart is here for New Orleans. We've been here for 30 years, and we suspect that with COVID-19, there's much more work we need to do. If you want to get more information, the website is listed there. The person who's probably best to contact through an email would be Daphne Ferdinand, Daphne P at healthyheartccp.org. And I'm so pleased for the opportunity to work with the National Minority Equality Forum and Laura and Sustainable Communities in this particular project. Thank you very much for this opportunity.
Rashida, I believe that you're next on our agenda. Thank you so much, Keith.
Thank you, Dr. Ferdinand. Can you unshare your screen? Okay. Great. I want to thank Sustainable and Healthy Communities, Dr. Larley Hall, Dr. Puckrin, and our partners in New Orleans for this opportunity to work with you all on the project for the past couple of years to address the importance of what we've been discussing this morning, the importance of diabetes education and prevention in our communities. I'm the founder and executive director of Sankofa CDC. Sankofa is a Akan word from West Africa that means go back to the past to build for the future. And we adopted this concept when we founded the organization in 2008. A number of our projects addressed community-led health prevention work through capital projects as well as direct health interventions and educational programs. The project that we worked on for this cohort was a peer-led diabetes and CDC prevention education program. And so I'm just going to speak a little bit about the work we've been doing for the past couple of years around that program and its impact in the community. A main part of this program is community health ambassadors, the three components. The community health ambassador component is critical to this program. It enables us to have this peer-led, discussion-centered approach to cardiovascular disease and type 2 diabetes prevention. The community health ambassadors come from the community in which they're serving and teaching participants. And so they're able to really support participants' empowerment to understand their health status and encourage them to know their health status. And they're recruited from the neighborhood as well as health systems. So we may partner with different healthcare clinics and providers, as well as going into the community spaces where these health ambassadors live, work, such as their churches, their schools, and neighborhood centers. They also help promote healthy eating habits through home recipes. So they're really a critical component of reaching folks and empowering them to be to address their preventative approach to diabetes and cardiovascular health. Another component of this program is the curriculum that we use. We've looked at a number of curriculums that address hypertension reduction and health education. We've looked at American Heart Association, the Empowered to Serve curriculum. And for this cohort, we've adopted the CDC Prevent T2 Lifestyle Change Program. And this program, as well as adopting that program, we've also adapted it to really meet the needs of our community, because it's a template that is used all over the country by different groups. But we knew that including these healthy cooking classes were really important. This is what people wanted to know, and just address how we can transition some of these recipes into diabetes-friendly and recipes with less sugar and also less salt. We also included self-monitoring of blood pressure with glucose testing with our partners from Xavier University College of Pharmacy, and continue to include that integral lifestyle coaching and diabetes prevention education. Something else that we included in the program were veggie dollars. We operate a fresh market, and one of our capital projects is actually the development of this market from an open air produce stand into a 3,500 square foot building, which I'm going to share with you at the end of the presentation. But participants receive vouchers for being a part of this program, which they can redeem for fresh produce at the market. The community health ambassador model that we have adapted starts with recruitment on a systems level and a community level. Systems level meaning we may talk to the healthcare system, the leaders in these healthcare systems. Community level means we go to these community-based spaces where the health ambassadors are actually leading their own programs in our community, whether they're health-centered or social-centered or faith-based. And we then implement training. The CHAs engage in lifestyle coach training following that CDC Prevent T2 curriculum for diabetes prevention. And we engage in post-training follow-up as well and continue to support the CHAs, whether it's with informed science and data, or they have teachers and coaches from the healthcare community who may do some classes and workshops with them. Participant recruitment is really important to this program. We make sure that we work with the CHAs and they are engaged and enrolled to recruit participants from throughout the community. And we continue to meet with them and give them the opportunity to also start to mentor new CHAs as the program develops. This is a slide. This is Ms. Cheryl Brickley, and she's in one of the community-based settings, a community center in the Lower Ninth Ward. It's the same community center that Dr. Ferdinand mentioned in his slide. We work with 5 different spaces throughout the 70117 zip code, and she's one of our community health ambassadors teaching this class and leading the workshop. The community health ambassadors also encourage the participants to learn how to take their blood pressure. So they self-monitor, they learn with each other, and have these peer groups that they meet with to do that. One of our outcomes from the program were knowledge that was increased through nutrition education as well as cardiovascular health education. And we found that 47.9% of our participants improved their knowledge of nutrition topics. And the nutrition topics that they learned were about sodium intake, ways to control sodium in their diet, overconsumption of sugar, and sugar-sweetened beverages. And we found that 66.7% had an average correction rate at the endpoint. We also found that they had an increase in cardiovascular health knowledge. They were able to identify ways to control their blood pressure and decrease their risk of cardiovascular disease. 86% of our participants identified a correlation between diet and chronic disease. This was out of 119 folks who were in this cohort, and then 47.1% improved their knowledge of CBD topics. So they understood what those risk factors were, and they were able to know what it meant to have an ideal blood pressure measurement. We also evaluated the outcomes, or looked at the outcomes and impact of our program, by knowing that they did face a lot of barriers, but they wanted to overcome those barriers, and they had their own testimonials that stated how they overcame them. Ms. Hampton said that she always tried to avoid fast foods and sodas, but this program really helped her realize what she thought was healthy has a lot of sugar and sodium in them, a lot of sugar and sodium content. So the label reading component of the nutrition education part of this program really helped her to understand it, to open up a new world for her of awareness. And she also enjoyed the group setting and the importance of working with the group and working with people who are in her peer group leading this program really was a great support to her. Ms. Truly actually lost weight. We took biometric measurements in addition to the testimonials and the direct engagement with people in the class. And she lost weight during the program. Her blood pressure decreased. And she learned as well that she can share this information. She shared what she learned with her family members, with her peers. And so there was that also that self-efficacy that was a part of this work. It was a behavior change. And that's what's important to us is to have that, we want to have those physical measurements change, is what we've been talking about during this presentation. We also want people to be really engaged and enrolled in their health and change not just their knowledge, but how they actually practice good health. Our program is located in the Lower Ninth Ward area of New Orleans, Louisiana. It's once a thriving community of 40,000 plus residents, and it's been decimated and hit hard by a number of factors and barriers to health that are consistently impacting the health and wellness, mortality, weight, and quality of life of people who live in this neighborhood. So we've been actively trying to, in addition to execute these health programs, also build a system that improves a sustainable way of life for people to live and give them what they deserve. Right now, we are in a position to really develop not just the health and wellness of people through educational programs, but the commercial thoroughfares and economic revitalization of the space. And this is one of our projects where these programs will be taking place. Right now, they take place in our headquarters, which is a community center, and it's a great space, but we want to connect this project to a healthy cooking facility. So we are working with our economic development office in the city and a fresh food retail initiative, which is a project of USDA, to build a center where the participants will have an actual teaching kitchen where they can actually execute the work through healthy cooking classes, and also have a conference space where they can meet and talk and engage with each other. So we are really honored to have been a part of this program and work with such a wonderful team of individuals nationally and also locally with our Healthy Heart Community Prevention Project partners, LSU Healthcare Center, and the Health Sciences Center with evaluation. The information that I shared wasn't the evaluation specific for our cohort during this period of time, but it followed this work all was integrated and working in the same essence. So we are really excited about the opportunity to do this work. And if you would like more information or would like to support this work in any way, just please contact us. And our website is sancofanola.org. And we also are on Twitter. Thank you very much.
Sheeta, thank you so much. That was fantastic. Your work is so amazing. So let's do a little bit of the preliminary evaluation. Henry, I wonder if you would be able to share with us for a few minutes what we found.
Sure. Let's make sure I'm sharing the correct screen. Hello, everyone. Good morning. My name is Henry Nuss, and I'm an associate professor at the LSU School of Public Health here in New Orleans. And I've worked with the diabetes program in looking at some measures for evaluation to show the impacts of the program in terms of health outcomes. So the main purpose of doing this evaluation was
We're not seeing your screen, Henry, if
Oh,
you're sharing it.
Let me try that one more time. Sorry, this didn't happen in our practice session. Share screen. Can you see it now?
Yes, thank you.
Okay, I'll start the presentation. Okay, so the purpose of this evaluation was to see how this program was affecting health outcomes in the disparate communities with Sankofa and Daughters of Charity. So these were high-risk communities that we looked at these data. So what we know about this particular community is that we see a higher incidence in the not only the incidence but severity of chronic diseases, including diabetes, cardiovascular disease, and overweight and obesity. So the way we did this is we collected data from 2 sites that have an established practice of providing health education and care free of charge to the community. As I mentioned before, Daughters of Charity and Sankofa. So we used a pre-post test evaluation design so that we could compare the impacts from baseline to about 6 months follow-up from the beginning of the program. So the way we measured this is we employed a tool, a measurement tool called the Patient Activation Measure, or PAM for short. It's a 13-item survey that we use to assess knowledge, skills, and abilities for an individual to self-care for their personal health, especially if they have a pre-existing condition that they're aware of. We also measured hemoglobin A1C, fasting plasma glucose, blood pressure, and body mass index. So the way the PAM works is it's based on a 100-point scale, and depending on where you fall on that scale, you're classified into one of 4 levels. So the first level is for the lowest score range, then that suggests that a person does not yet understand their role in their own health and that it's important. They fall within level 2. That suggests that the person doesn't have the confidence and the knowledge to take care of themselves health-wise. If they fall into a level 3, that suggests that the person is now starting to understand the importance and relevance of taking care of themselves, following better health behaviors, taking medication, things like that. And level 4 means that they're really in a stage of maintenance about taking care of themselves individually. They're practicing healthier behaviors, they're following medication guidelines, they're eating healthier, they're exercising, and it's a sustained effort. So we collected PAM surveys from a total of 20 individuals at baseline and 16 at follow-up, with 14 that completed both baseline and follow-up. As you can see here, that the PAM scores did increase. Because of the sample size, it wasn't a very robust analysis, but we did approach statistical significance at a p-value of 0.08. So you can see both Daughters of Charity and Sankofa had increases in their PAM scores. So that means that as a result of this program, their ability to self-care is increasing. Now, baseline and follow-up BMI values did not really change. That's not too much of a surprise because I don't think for this particular study, the focus was on weight reduction. It was focused on diabetes, but we did measure those anyway, and we didn't really see a movement here very much. However, we did see a reduction in fasting blood glucose levels. So if you look at the orange bars, that's Daughters of Charity, had a fairly significant, well, again, because of the sample size was not statistically significant, but one can argue that that is a very obvious trend of reducing from baseline to follow-up. And Sankofa actually had very good fasting blood glucose levels at baseline as well. We then did a correlation between blood glucose and PAM scores, and there turned out to be a negative correlation, which in this case is a good thing, because you want to have lower blood glucose levels the more confident you are that you can and will take care of your own health. So that's exactly what this chart is showing here. Similarly with hemoglobin A1C, we see that the values decreased from baseline to follow-up. Again, not statistically significant, but that is because of the sample sizes. This was a pilot program. So you can imagine that if we had maybe triple the numbers, that we would see much more statistical relevance. Here's a correlation between hemoglobin A1C and PAM. Again, a negative correlation is what we like to see, and that is what happened based on the data. So a negative correlation between being more confident to take care of your own health and has the result in lowering A1C levels. Blood pressure, we saw a downward trend between systolic and diastolic. We saw that Sankofa participants approached statistical significance, but it's fairly clear that there is a downward trend on both systolic and diastolic blood pressure measures. And once again, a negative correlation, which is a good thing, between blood pressure and PAM scores. So we can say then that that correlation is I think this one might have actually been statistically significant as well, because we had a decent amount of measures for that one. And then with the diastolic pressure, the same negative correlation. So our major takeaways from this is that although baseline PAM scores were relatively high, that they did improve. Some of the particular statements that we saw improvements on are, I am confident I can figure out solutions when new situations or problems arise with my health condition, and I'm confident that I can maintain lifestyle changes like diet and exercise, even during times of stress. We also saw that the PAM measure performance tracked well with the other data elements, and noticeable improvements for blood glucose, A1C, and blood pressure, but not much of an improvement for BMI. Results were statistically hampered by small sample sizes, but the clinical relevance is very promising. I think that's it. Thank you.
Thank you so much, Henry. It was very exciting to see that the efforts of peer teachers like at Sankofa did empower the patients to work on improving their health. Last but not least in our presentation list is Ms. Helen Artiego Landaverde, who is, as I mentioned at the introductions, an amazing woman who serves her community so hard hit in this COVID period. So I'm going to turn it over to you, Helen, and welcome.
Good morning, everyone. Thank you so much for having me. I'm honored to be among all these experts, and I always learn something new every time I listen to Keith, and I'm super impressed by the work and the Fresh Stop Market. If you guys can replicate that and bring it to New York, I happily will find you a place to have that here in Queens, because that's so needed. So I'm just going to share my screen now. And alrighty. So I am from Urban Health Plan, which is a network of federally qualified health centers. Sorry. Federally qualified health centers are basically federally health centers funded, which basically says that we see everybody regardless of the ability to pay. Urban Health Plan has sites in the South Bronx, Corona, and in Harlem. We're a total of 11 health centers. We have one Article 31. We're very excited about that to provide mental health. We have 12 school-based health clinics, both in the Bronx and Queens. And we're about 950 employees plus. All of our sites are Joint Commission accredited, and all our sites are NCQA level 3. Our area of focus, like Laura Lee was mentioning earlier, is Corona, Queens. Sadly, we were the epicenter of everything, but also pre-COVID, we were also the epicenter of high disparities of healthcare. Comorbidities like diabetes, hypertension, obesity was already hitting our community kind of really hard. Plaza del Sol is a team of 86 and 16 medical providers. Most of them, out of the 16, 11 are family practitioners. So in Queens, we like to do family visits. We opened in June 2009, and I always choke up every time I say this. We opened in 2009 with 38 patients. And now year to date, we have about 29,000 patients that we service in Plaza del Sol. We do about 59,000 visits annually. And we stayed open throughout the whole pandemic. It was basically, we were the last of the Mohicans. It was us and Elmer's Hospital that were open in our community. So I think that's a great strive and our testament to our mission. So why diabetic patients? Like most of our other panelists have mentioned, they are the highest risk. They are also the highest risk for influenza. When a diabetic patient gets flu, they are triple the risk of being hospitalized, and then quadruple the risk of being in the ICUs in a hospital. So for that special attention, we wanted to focus on them just because the risk was just too high, and the prevalence of diabetic patients in our population was high as well. So we thought we could make the biggest impact there. Working with Laura Lee's team and being a type A team at Plaza del Sol, one of the things that I thank Laura Lee and the Drive team so much was step one, which was the learning. This is painstaking because, you know, as providers, we're ready. We want to go see the patients. We want to give the flu shots. We want to do the education. But taking this step was super important because it really let us do the research, do the surveys, do the focus groups, and really listen to the patient needs and really focus and learn what are the true barriers the patients are facing. And we kind of put this like in buckets. We use the Anderson behavioral model. We learn what environment is keeping our patients out of not getting the flu shot. What are some populations like predisposing, ambulant, and need? What behaviors are affecting the flu rates acceptance, and what other, like what's our main outcome to making sure we increase flu vaccines in this population? This took about, I want to say about 3 to 6 months to completely do, but worth every minute, and I think was the secret sauce of our success. Step two was the training. And as Laura Lee mentioned at the beginning of her presentation, we were part of a special group that got special training. Sorry. And in year one, we focused just on the clinical team. But once we really looked at the learning piece and what was keeping our patients away, we quickly realized that this is not just the provider, the nurse, the clinical team. This involved everyone, from the patient advocate to the janitor to the secretary. Like everybody needed to get trained on the importance of increasing the flu vaccine uptake. And you can see that our rates went up a lot between year one and year two. So that training was also very impactful in the work that we did. And then if you look, when we take step one and step two and we put them all together, implementing everything, one of the things that Laura Lee and her team, Naomi, always tell me is like, don't reinvent the wheel. And they put us, I didn't even know this existed in the CDC, but they already have information of 3 simple steps where everything is in Spanish and English. So this was quick. We were able to print them out in color and give them to our patients. Laura Lee's team sent us posters to put up. So this was a quick win to spread the word. The second one was that we discovered is, besides the training, is that we needed our patients to have full access to flu vaccines, right? So we created a walk-in service just for flu vaccines. Patients wanted to come in and out. They didn't want to see the doctor. They just wanted to get their flu vaccines. Because one of the things that we did in our learning, in our focus groups, a lot of our patients were afraid to go into pharmacies because of the language barrier, the cultural barrier, and the trust barrier. One of the things, they felt trust inside Plaza del Sol. They felt like if they got the flu vaccine, they were getting the right one on the right arm. And also they were getting it quick. There was that trust factor. So we made it RN standing order where the nurse could just give the flu vaccine without a provider order, which not only sped up the visit, but also it increased our rates as well. The other thing that we did is use our EMR system, eClinicalWorks, and using the CDSS alerts, well, I'll show you in a little bit. And then the fourth thing that we did based on our training and our research is that we needed a second RN just to be hired to manage the flow and reduce the wait time. Because one of the things that we did, most of our population can't afford to take a sick days off. Like one of our panelists said, they're essential workers. They don't have time. They don't have sick days. A lot of them work in restaurants. So they don't have the benefit of having a sick day. So for them, getting the flu shot was not so much of a prevention. It was a prevention of not getting sick, hence not affecting their economic situation. So a second RN was super important to hire and manage and reduce the cycle time. So this is kind of what I mentioned in our step 3, using the CDSS alerts. I don't know how many people out there have eClinicalWorks. So this is kind of like a feature that they have in their EMR. And what we did, which was like so simple, I don't know if you can see, we literally included influenza high risk. I mean, it was as simple as just adding it in there. And if the patient showed up that they didn't have it, it would show up in red. And this was a quick way for our doctors when they're seeing the patient, especially diabetics, when we see them every 3 months, for them to say, hey, you didn't get your flu shot, we'll give it to you right away. And here's some data. So, data never lies. So you can see before we implemented all these changes and did all this learning process, you could say we were at 66% in 2018, and we jumped in 2019 to 73%. And this data is just for diabetics. And then you can look, all this work, which is what I tell already is most important, is that it sustained itself even during the pandemic. The process was so embedded in everyone that even as we shifted into telemedicine and we shifted in dealing with COVID, it did not change the behavior of our team. Flu vaccination was still important. So you can see here, as of September 2020, our rates are still 70%. We're off by 3, but we're very, I think by the end of the flu season, I think we'll show a very nice number as well. So how did this, I thought it was also important to show how it affected overall of our patients. And you can see when we include all of our adult patients over the age of 18, you can see by even just focusing on the diabetics, we actually help the overall community, kind of like one of the other panelists has said, this whole natural learning of peer-to-peer and community to community. The diabetic patient will tell the mom who's pregnant, will tell the mom that's pregnant, will tell the grandma, so that kind of sharing and learning from each other does exist. So I kind of agree with Henry about the PAMs, that patients will get more confident in how to manage their healthcare. So, and this is like proof in the pudding, right? Because while we were focused on diabetics patient, the community knowledge spread to our overall patients, and this organically went up. So you can see that as well. This is just a different view. So you can see that we were able to sustain patients overall. Even during the pandemic, you could say we stayed at 69%. So our new norm, post-COVID, I'm hoping there is not a second surge, but if it is, we're ready. So what has happened to us? How have we been able to sustain the work that we've been doing pre-COVID and now post-COVID? I think like many organizations, we had to pivot and we had to get very creative and innovative how to meet our patients. But one of the things that I think went so well for us, or our secret sauce, was that learning piece, that step one. Really learning what our patients were looking for. And one of the things that we learned right away was that our patients want the flu shot fast, quick, in and out, right? Because they cannot afford a sick day. So in thinking that, and now post-COVID, what's our new norm? So our new norm is, how do we provide that service? So we created a tent outside only for flu vaccines. So this is our amazing, this is our LPNs and our amazing team that give the vaccines outside. And I have to tell you, on a daily basis, they give anywhere from 100, because right now we're in the midst of flu season, they give anywhere from 110 vaccines to around 90 vaccines a day, just by having this tent outside. So I'm very proud of my team. I think the stuff that we've learned, we're super excited. Our next phase is to try the Drive toolbox. So we're very excited to try to do that as well in this coming season. And, you know, I think one of the things that has been a great to our success is that we don't give up, and we get innovative, and we try to meet where our patients are at, and our community has benefit from it, and so has our workforce. And if anybody has any questions, please email me, or you can call me. Here's my cell. And, you know, thank you again for having me here and letting us share our little story with you guys.
Helen, thank you so much. I can't wait to come back up to your location and see your wonderful team. We have a couple of questions in the Q&A box. I know we're at the end time, but I wanted to let you all know that the next session is going to be starting about 10 minutes late, as the moderator had a last-minute emergency. So we have a little bit of extra time. So let me provide, I did see that someone noted that some of the slides weren't visible to them, and I will work with the presenters to make sure if they're comfortable to share slides with anyone who reaches out. So questions I've got on my Q&A, and please feel free to write some more Q&As if you want. Let me start with you, Dr. Ferdinand. There's a question about pneumonia vaccine in addition to flu during the COVID pandemic. Do you have any suggestions for the group?
Yeah, I think in general, vaccination should be done, especially in persons with diabetes and older people. The Pneumovax vaccine has to be given in 2 doses. I highly recommend it. If you look at causes of death, conventional influenza kills anywhere from 35 to 50,000 people per year. COVID-19 is the 3rd leading cause of death right now at 210,000. If you add 50 on top of that, even if COVID-19 didn't kill another person, you're now at 260,000 people. We need to do influenza vaccine. And for those who are high risk, we need to do pneumovax vaccine on top of that. I've done them all. And I think what happens right now is that people are anti-vax. What I'm going to say now sounds odd, but you can do your own real research in validated sources. A lot of the anti-vax stuff comes from Russian bots, the same people who are confusing you in terms of your election and in terms of your politics want you to believe that vaccines are bad.
Thank you very much, Keith. Another question came in for you, Dr. Puckrin, in terms of explaining the underlying factors of why patient risks are increasing, leveling to financial risks.
Well, the real challenge is, of course, and I love the work that Kofi and Dr. Ferdinand and the Health Center in New York, Helen's Health Center, because they're really talking about managing patient risk. But a lot of what's going on in our healthcare system is management of financial risk. 1 second. Yeah. Is managing financial risk. And it's really different because if you look at the way we're thinking about healthcare, at least here in Washington, the conversation is always about money. But what is not appreciated is when you deny patients access to medications and therapy and physician office visits and all of those things, you are going to elevate their risk. You are going to change their risk profile when we have the science to actually treat them better. And so a lot of the work that you're doing with your quality improvement initiatives and the advocacy work that we're doing at NMQF is really focusing on patient risk, and we're pushing back on the idea that financial risk ought to be the prime directive of our healthcare system, because what you see in the data is that we're not getting the improved outcomes that we should see over 20 years. We can do a lot better.
Thank you, Gary. I guess I'd like to ask the whole panel, if you would, in a moment or two, talk about if someone wanted to implement a program like you've done, training patients, meeting some of their needs in terms of social determinants, really making your practice meet the patient needs. What one step would you say would be good for them to take to get started?
Have a
Keith,
direct contact with the community. I was on a call with some academics last week, and they were talking about the need to get the community involved. Well, you don't get the community involved after you've set up a program, after you have done an intervention. You get the community involved in the design and implementation. For instance, what Helen does, having her clients suggest to her what really is needed, and then she models that. Rashida has the working group with the community health workers who are community members who do the actual education. And even though I have all these letters behind my name, I still see myself as a kid from the lower Ninth Ward. And I think one of the reasons we are successful, why people come to hear me, is not because I'm this Tulane professor, but it's they're gonna go hear Keith. They're gonna hear what Keith's got to say. So the first step, you got to get people who are part of the community to work on these programs.
Excellent. Rashida or Alan?
I agree with the doc. I mean, I think one of the things that you have to do is listen, and that's part of the learning. You know, taking the time to ask those difficult questions, you know, and patients will tell you, the community will tell you up front what they like and don't like. And you have to be like, you know, because you're thinking you're doing this all amazing work for them, and you've thought of all these amazing ideas, you have all these resources, and they're like, no, we don't want any of that. We just want to be in and out. And I think being honest on what our patients and our community needs, and know that it's not a cookie cutter. And I think that's why that step one is super important, of learning, like taking the time and doing the surveys and the focus groups are important.
I think what's also really important is for people to really know the information. And what's happening now, presently, which has been different than over the past years, is data is becoming a lot more accessible and transparent and relatable to people. We have these infographics, we have new media, so we have ways for people to really understand where this information is coming from and why it's impactful. And so I was really impressed with the data that Dr. Puffrin's been collecting over these past 40 years. It's amazing, and people, you know, should see the trends and what's been happening over this period of time, and knowing what's going on with pediatricians who are really concerned about more children getting diabetes at such an early age and how that's impacting their lives. Because we just kind of move through life and we don't think about the large systematic, you know, impact of this on our lives. So that's an important part of our work, is the folks in the program want to know for sure, like, what's happening internally in our body. How does the heart work? How does the vascular system work? What does it look like? My father used to have these cholesterol these models of arteries with cholesterol in them, and you can see the plaque in the arteries. That visual is important, and if people can see visuals and not just models, but also data and statistics, and know that how this is really important to them, not just for their personal lives, but their, you know, peers, their colleagues, their community lives as well, their neighbors and friends, is helpful.
That's great. Henry or Gary, do you have any additional thoughts about what might be a good first step or a critical ingredient?
I think I would agree with Dr. Ferdinand and Helen and Rashida. Healthcare is actually a collaboration. And as part of that collaboration is the community. You know, we get these degrees and we think we're separated from the community, but we're really not. We can't do our work without full engagement of the community and creating that interaction so that you're translating the data into actionable bits of information that can help people change their lives. And that's what I really love about the work that you're doing and the work that Rashida and Dr. Ferdinand and Helen are doing. They're actually in community, changing lives by taking data that sometimes is difficult and hard to understand and packaging it in a way that can have meaning for people in everyday life.
Thank you. Henry, do you have a thought?
Yeah, I'll just piggyback on the back of that last comment. I think it's important is translating the data into something that is consumable, not just for researchers, but for people who live in the communities that may not understand the technical jargon, but are certainly more than competent enough to understand what's moving the needle for them in their communities. And I remember you put up a slide earlier where some individuals in the community weren't even aware that things that are labeled as healthy and nutritious aren't. If you look at the labels, and something as simple as just looking at the labels and being able to interpret the information there, it can be a very, very powerful tool in helping individuals take control of their own health.
Thank you, Henry. I'm putting up my slide again because I want you all to see my email address. We really would welcome all of you to become part of this network and become peer leaders just like those you've seen today. Folks doing fantastic stuff. We'd love to support you in your work and help you have an impact on others as well. There is information in the chat box about the next session, so please take a look at that. We thank you, all of us, for your time today and your attention. So delighted to see over 100 people participating this morning. And most of all, I want to thank our colleagues who presented today. Thank you for all the important and great work that you're doing. Have a great day, everyone, and thanks again.
Bye.
All right.